Hi everyone, thanks for coming tonight. My name is Abby Haas and I'm the Economic Development Director for Lafayette County. If you guys remember from our previous RAD presentation, we invited Michelle back once again to present to the county board. Michelle is a rural health expert with over 2 decades of experience working with critical access hospitals and rural health organizations. Tonight's session will focus on the economic impact of rural hospitals, clinics, and the overall impact of rural health on local economies. And with that, I'll turn it right over to Michelle.
Thank you. I'm going to be working with both, so it's nice to be back, and I'm so happy to be up here vaccinated so I can take off my mask and see you all this time, so thank you for having me back. I'm not here alone. I have reinforcements, and I'll introduce them to you in just a moment. As Abby said, it's hard for me to even wrap my brain around that I've been working with critical access hospitals for over 2 decades, but I have. And there's one thing that we say often is if you've seen one critical access hospital, you've seen one. But what we do know is that every single critical access hospital in this country faces many of the same challenges, and with that opportunities as well. So tonight we are really going to be focusing, as Abby said, on economic impact. Not specifics about your replacement facility per se, but just giving a really good, as we said the first time around with USDA, just a listening and learning session. We have a lot of things to share with you, and we want to listen and learn from you as well. A couple of housekeeping notes. We are being recorded, and so just let you know that, full disclosure. There's some note cards in front of you. I'm not sure if they made it to the table or they'll be coming around. We will have room at the end. I know there's a packed meeting. There's many people here this evening, so as you hear things, write down your questions, because if we can't answer them tonight as it relates to the economic impact, I know that Kathy and Molly and the whole team at the hospital will be interested to make sure that your questions are answered, because no one should have a question unanswered, and there is no such thing, as we know, as a stupid question. So we'll just put that up right front. I'm trying to think if I missed any other housekeeping notes. I don't think so. Did I? Okay, gotcha. So let's just, we'll get started here. I am not here alone. As I said, I'm really thrilled to be joined with experts who know a lot more on different subjects than I do. So Marie Berry and Jeremy Levin are here from the Rural Wisconsin Health Cooperative, and they're back there. They'll be coming up and presenting as well. And I am super thrilled to have with us Brock Slayback. And I've known Brock for like a long time, and we run into each other at conferences, but he is the Senior Vice President of the National Rural Health Association Member Services. And what that means is that there's not a rural hospital or clinic in the United States that he has likely not worked with, visited, or done some kind of consulting work and support work, because he's here in a supportive role. Another thing I will tell you that I think is important for you to understand about the National Rural Health Association is that they are an advocacy group for rural health. And last year, February of 2020, I happened to be in Washington, D.C., just as all this was happening in our world, and I facilitated a panel discussion on the crisis of rural hospital closure. So we are going to be talking about that as well today, because as you can imagine, COVID has impacted rural hospitals in this state and many others. And you'll be surprised, I think, when you hear some information that in the state of Wisconsin, you've entered into a category that you have not been in before, and it just has so much to do with all sorts of policy and reimbursement and whatnot. And I'm just going to plant a seed thought in your head. If you've ever heard of an organization called the Brookings Institution, they created a map that was released very recently. Oh, they call it a spaghetti graph. I refer to it as a hot mess, because what you'll see is how complex rural health is in this country. It's not cut and dry. So you might see a hospital in the corner and think, oh, they deliver care, there's ER, there's a lab, there's imaging. But all the things that go up behind the scenes are important, because again, it's important for you to be able to make informed decisions. So Rural Wisconsin Health Cooperative, they'll tell you more about them, but you can see here they're an incredibly important collaborator and support network in your state. They are established in 1979. As you can see that they have 43 rural acute general medical surgical hospitals that really drive that organization and what they do, and they'll tell you a little bit more about their work, and as I said, the National Rural Health Association. So if you are curious, I know both their websites have great information, great papers you can download, and we'll make sure that this makes it into the notes as well so you can do some of your own homework. I love this quote. I'm trying to think how many years ago it was, but I produced a very short, not critically acclaimed, documentary film on the role that critical access hospitals have in their community. And this is something that I remember that you guys said for all those years ago. A hospital is often the centerpiece of economic viability in rural America, providing jobs for a community's residents and resources for its development. So it's not just a place that you go when you're not feeling well or when you need someone to care for you. There is so much more behind the scenes than you may know. So here are the 4 objectives for our meeting this evening. Number 1, you always have to have objectives, right, if you're going to accomplish anything. Inform you, the stakeholders, about the state of America's critical access hospitals. Understand the economic impact of Memorial Hospital, Lafayette County, and Lafayette Manor in your county. Increase your knowledge about healthcare jobs and wages. I think that's something that so many people kind of overlook about what it means to have these kinds of high-paying jobs in a community such as yours. And of course, at the end of the day, if you leave here this evening and say, Michelle, I didn't learn a single thing, I'll own it. I'll be heartbroken, but I double dog dare you not to learn something here that enlightens you. So let's start there. This is the way that we kind of prepare the presentation. How many of you are familiar in your previous or your current life with a SWOT analysis, right? Strengths, weaknesses, threats, opportunities. So the way that we did this was strengths. We're going to cover jobs, wages, direct and indirect benefits, partnerships and collaborations, and what that means for you from an economic standpoint. The weaknesses. And we know that your healthcare facility at 70 plus years old does have some weaknesses. Of course, the current facility, regional competition, we have to talk about that. Truth and trends about rural hospital mergers and acquisitions, because I know that's a subject matter that is on some of your minds, as it should be. And so we'll be talking about the realities there. And then finally, we'll end on a good note, which is about the opportunities, which I see you have more opportunities than anything else here. A replacement facility, the economic impact, what that means for recruitment and retention. You're going to hear some about that this evening, which is really an interesting component for all of this. And then the quality of living. I always ask an audience like this, how many of you here wish to live in a diminished quality? Nope, no takers? We all want a good quality of life. And so we'll be talking about what does that have to do with economic impact. All right, so with that, I am going to bring up probably a man who knows more about critical access hospitals than the law should allow. And I'm going to hand it over who flew in here, and boy, his arms must be tired, from Canada. So Brock, thank you so much for taking the trip with us.
Thank you.
I'm on you to these.
Yeah, you're welcome to. Thank you, Michelle. And it is a delight to be here in Lafayette County this evening to share some time with you. I am extremely impressed with the engagement for the community support of your hospital. And I think that's an incredibly powerful testimony to the work that you all are doing here. I had the opportunity this afternoon to visit with Kathy and Molly at the hospital and get a nice tour of the facility. And you have a lot to be proud of. And certainly it's really an asset, as Michelle said. So the first question tonight is, what is a critical access hospital? Back in 1983 or so, we changed our reimbursement formulas for Medicare. And that Medicare change, and I won't go into all the gory details of what that included, closed about 400 rural hospitals in the next 10 years. So in about 1992, policymakers in Washington woke up and they said, well, wait a minute, how in the world are we going to keep our rural hospitals open? So in 1992 to about 1997, we created all kinds of policies that really helped to sustain rural hospitals. What are some of those things? One is the implementation of the state offices of rural health. One is the FLEX program, the Rural Medicare Flexibility Program, which provides technical assistance to rural hospitals, and I know Wisconsin has a very powerful and vital program doing that. And then in 1997, as part of that program of sustaining rural hospitals, we passed the Balanced Budget Act. Now, the Balanced Budget Act of 1997 included a lot of things. It was a really thick bill. But what it really did, at least in terms of importance for us, is it created the Critical Access Hospital Program. Essentially, it rolled us back in reimbursement to what we started with in 1966, and that was cost-based reimbursement. So I like to say we went back to the future. We actually went back to what we started with in the beginning. And so that cost-based reimbursement has been what has really propelled and sustained facilities nationwide. And you're blessed to have your hospital to be a critical access hospital, getting this payment mechanism that really rewards low-volume facilities. So the PPS system, the system I told you about that was created in 1982, it rewards high volume. So if you're a Milwaukee hospital or a Madison hospital, you did quite well in that system. But for small rural hospitals like here in Darlington, that was not the case. Next slide. So we have then, I remember fondly back in 1997, the gray hair here will tell you that I've been around a long time in this business. In 1997, starting off in 2003 or so, we had maybe 10, 15 hospitals that converted to critical access. Then around the 2003 and on to about 2010, we had a rapid expansion of the number of those that converted. Right now today we have 1,350 critical access hospitals, which is a huge number. Most policymakers in Washington had no idea that there was going to be that many. They estimated when they passed the Balanced Budget Act that it would be about 350. So you can see how desperate rural communities were to keep their rural hospitals open. So here's a map. You can see them saturated all over the United States. All 50 states, pretty much, except with a couple in the Northeast, have a critical access hospital. But look at the concentration in the Midwest. Starting up in Oklahoma, Kansas, Nebraska, going into Wisconsin, Minnesota. We're in the states that have the most number. Kansas and Nebraska, Kansas is where I'm from, we compete with each other for the most number of critical access hospitals in the state. And so a critical access hospital can be county-owned, it can be, or government-owned, it can be independent 501c3, meaning a nonprofit, or it can be a for-profit or owned by a system. So there's all kinds of ways in which a critical access hospital can relate to getting the federal reimbursement that's required. So what are the challenges of a critical access hospital? Well, I already mentioned to you something already, and that's low volumes. Low volumes is a trend, is an issue that all rural hospitals face. It's not uncommon. But the way I like to look at it is that we live in a society where we are equally distributing resources from urban to rural and rural back to urban. Where is all of the energy and all of the food produced? It's right here in Lafayette County and counties like yours all over the country. And I believe personally, coming from rural Kansas, that we deserve and expect that same level and quality of care that the folks in the urban areas should get. And so we consider this to be an exchange. And I think that we have the emergent needs. Obviously, the emergent issues are obvious. One is COVID. COVID has been in 2020 and 2021 has been a huge impact, and I think the rural hospitals have really helped to serve the continuum of care that are required to keep patients safe in this pandemic. Back just a couple, there we go. And then the recent ones, there's all kinds of variables here that you can see that are listed. Economic shifts. We have demographic trends in our rural communities, typically older, poorer, and sicker, I like to say. Some of the characteristics that are different than some of the urban counterparts. And then those things that are persistent, and I mentioned one of those, and that's low patient volume. Next slide. So the crisis is colliding to create right now a unique time in our history. So the rural hospitals with negative operating margins in 2021. This is a distribution of all the states and the numbers of hospitals in each state coloring with a specific color that represent the concentration of hospitals that have negative operating margins. So I'm going to walk over to the screen and give you some examples. So 46% of critical access hospitals, rural hospitals nationwide, are operating with a negative margin. Kansas, Missouri, Iowa, Arkansas, they're in a darker color on the screen, which means that they're further over in the number of hospitals that are operating in a negative margin. Now, you all are blessed in Wisconsin to be in a lighter blue color, which puts you in the 21 to 40% range in the state of Wisconsin. So that's good. Relatively. Hospital closures, as of May 3rd, we've had 136 hospitals closed nationwide since 2010. This has been, our high number was in 2020, we had 19 hospitals closed in 1 year. Again, we're distributing these across the United States. You can see Tennessee and Texas are the two states that have the single highest number of hospital closures in those states. Texas is because they're a big state and they have a lot of rural hospitals. Tennessee, a lot of economic conditions in some of the rural parts of that state that are impacting their operations. Next slide. So our data partner is Chartis Health Analytics, and Chartis and us worked up a model that began to predict those hospitals that are vulnerable to closure. So we've had 136 that have closed. What about all of the other 1,300, 1,500 hospitals out there? How many of those are vulnerable? So we took the financial statements of all of the closed hospitals a year before they closed, and we overlaid those on the operating expenses and financial statements of existing hospitals. And here is the number that we came up with. Out of the roughly 1,800 rural hospitals, 453 are vulnerable. And out of this, and so you can see the concentration here is the darker the color, the more that state has hospitals that are vulnerable. So again, you're seeing a trend. Mississippi, Tennessee, Oklahoma, Texas, Missouri all have high concentrations of vulnerable hospitals. Compared to Wisconsin, you're not as light in terms of coloration, but it's not nearly as dark. So you're kind of in the middle in terms of the number of vulnerable hospitals in this study. So talking a little bit about demographic challenges and the social determinants of health, Michelle and I were talking about that on the way over to our meeting this evening, and how it's so important for hospitals to become engaged in the community, particularly as they start to approach issues that go beyond the traditional hospital services that are being offered. And so what we look at is an older population in many rural communities. The rural percentile is 69 versus 35 in an urban area. Diabetes, this is just one marker for chronic disease. We have a lot more chronic disease as a percentage of the population in rural communities than we do in those communities that are urban. Veterans, interesting, there's a higher proportion of people that are veterans of war that live in rural areas versus in urban. Now, when we look at the metrics for access to care, meaning primary care providers, and in this case, mental health providers, it's just flipped. We don't have the professionals that we do and need in rural communities in order to be able to treat the disease burden that we have, especially as it relates to chronic care. Just a side note, chronic disease is going to bankrupt this country over the next 20 or 30 years if we don't get a handle on it. This is an issue that is persistent, that we're going to have to really be creative about how we start to solve the problems of our community. And a lot of those problems are related directly to the social determinants of health, those things that are not directly health related, but impact health in an indirect way. Next slide. So in this arrangement, we have all of these issues that are impacting the rural hospital here in Lafayette County. Health disparities, population migration, recruitment, retention, the recent pandemic with COVID-19, economic policy, and healthcare policies. All of these are what's making Kathy and Molly's job and the board that operates your hospital even more difficult in these changing times. Next slide. So our friends at Chartis did a stability of the rural health safety net, and we really just rolled this up into regions of the country. And so you can see in the Midwest, which includes Wisconsin, you can see that the vulnerability may foreshadow closures. You're not nearly at the epicenter like in the Deep South, but you are in a point where if current trends don't change, the rural parts of places in the Midwest could become like the South if we don't start to make policy changes and choices differently.
I just want to say, Texas has 85 counties without a health facility. So just for some context there.
Yeah, they have what we call medical deserts, places where there are no medical services. Next slide. So the common characteristics of vulnerable hospitals, and this was due to, and I'll talk about some research that we did in terms of predictors of hospital closure. But here are what we have looked at around the country as being some of the markers of what could be a predictor of a vulnerable hospital. Market share, quality, population, patient perspectives, those are the ratings of how your patients perceive the care that they receive, financial instability, lack of providers, and then lastly is an aged physical plant. And those are all the things that go together in that context. So in our research, we looked at the variables that impacted the predictors of hospital closure, and these are the elements that popped out of that, and you can see what matches with MHLC as market share, population, and aged physical plant as being some of the predictors of possible problems for the hospital going forward. And then I think, this is Marie?
Yeah. So you're coming back up, so don't.
Okay, I'm not going to go far, so
We're
thank you.
going to have Marie and Jeremy come on up, and they're going to do some more deep dive into the economic impact.
Thank you,
Yeah,
thank
I
you.
thought it was important for you to have a good overview so you know what we're talking about.
And hi, I'm Jeremy Levin, Director of Advocacy. And just before I introduce my colleague Marie, just to let you know a little bit about the Rural Wisconsin Health Co-op. Again, as Michelle noted, 43 rural hospitals throughout Wisconsin. 35 are critical access hospitals, just like Darlington. 8 are rural PPS, and we represent probably about 60% of the rural hospitals. We are a true cooperative. Our executive director, Tim Size, who started the co-op back in 1979, just took dairy cooperative bylaws, crossed out dairy, and wrote in hospital. So that's our start. And we do a lot in education. Advocacy is also a shared service. We do other workforce and even clinical offerings. And actually, Darlington is where we offer some of our largest clinical offerings, starting back in the mid-'80s with physical therapy. We do speech therapy. We have clinicians here in town, occupational therapy, audiology. So you probably, if you've gone to the hospital, or even some of those who are working back there, have dealt with a rural Wisconsin health cooperative employee. Also, just to give you some context too, there are 58 critical access hospitals throughout Wisconsin. I would say we're in, as Brock said, we're in a stronger position than a lot of the country. We have higher quality, and that also then breeds some stronger financial position. And I think with that, I will then turn it over to Marie.
It's a pleasure to be here this evening. Thank you so much for letting us come and chat with you. When I sent Michelle my slides, she put my opening line in quotes, and I thought that was very fancy. I don't know that I've ever seen my words quoted before. So I understand that some people in this room may not receive their health care at Memorial Hospital of Lafayette County. So what we're going to talk about tonight, and my portion of the presentation, is how the hospital still benefits you, even if that's not where you see your doctors and not where you receive your health care. It's still a really major employer in your community and has economic impact that helps the county as a whole. So we'll just dive right in. So total in Lafayette County, you have an all industries employment impact of 4,180 people. And when you look at both the direct and indirect jobs impact of MHLC, there's 237 total jobs impacted by the hospital's presence in your county. So about 5% of the jobs in the county are directly related to the economic impact of your hospital. And this is on par with the impact of critical access hospitals in their communities across employers. So many employees in the county here receive their paychecks from your hospital. And the education and health sector as a whole is one of the top 3 employment sectors within your county. So having the hospital here drives many of those healthcare employment numbers. And in terms of wages, it's also one of the strongest economic drivers in your county. Total wages from the Wisconsin Department of Workforce Development, $160 million in Lafayette County, and MHLC's wages, both direct and indirect, come out to about $50 million, which is almost 10% of the wages and salary expenditures in your county. And this is actually a little bit higher than the average critical access hospital in the country. So it's good, right? You have an outsized impact from your hospital in your county, which means that they're helping to employ people and drive good quality wages and benefits within your community. So the healthcare sector as a whole traditionally has higher wages than other sectors within rural counties, and this is also true within Lafayette County. So this data specifically is healthcare practitioners and technical occupations, and so those are the people who are the boots on the ground, right? They're the people who you see when you walk into your doctor's office. This isn't necessarily including administrators and those folks. So within Lafayette County, $17,000 is the difference between your mean wage for all industries and your healthcare industry. That's a big jump. That's what some people make in a year, right? So these are really high-paying jobs within your community, and those high-paying jobs relate to the tax income that you guys see when you make your budget every year, and I know that's a challenge for every rural community. You always have limited resources to work with, so it's important that you have these high-paying jobs within your communities. And that carries down to your experience wages and your 90th percentile wages. And just to clarify that a little bit more, so a 90th percentile wage is defined by 10% of the people within the occupation are making more than $111,000, and 90% of people are making less than that. So you do have some folks making above that 90th percentile wage, but it just is a way to illustrate that healthcare workers are high-paid workers within your community, which contributes to your tax base and is helpful come budget season. And this holds true across the state. So these charts show the whole state's hospital and healthcare workforce, and as you can see, those are the, here, I'll come over here so I can show you guys. The red and gray lines here are hospitals and healthcare, and then the red line, or the blue line is total employment. So hospital and healthcare employment is growing at a faster rate than total employment, which means it's bringing more jobs into your community, which is always positive. And also the wage and salary income for those individuals is growing faster than total wage and salary income. So, and like I said earlier, these statistics hold true across the country. So according to USDA, on average, rural hospitals account for 8.5% of the total wage and salary expenditure in rural communities, and you guys are closer to 10%. And then looking more specifically at your hospital, so this data, just so you're aware, comes from the Wisconsin Hospital Association and their work with economists at UW-Madison to illustrate the direct impact and indirect impact that your hospital has here. So even if you're not receiving your health care at MHLC, these are the things you should be thinking about when you think about the future of the hospital, because there are huge economic impacts. You know, the total revenue impact of $38 million within your county coming from your hospital. And now we're going to dive in a little bit more specifically to what that means for each doctor within your community or each advanced practice provider. So one rural primary care physician equates to $1.4 million in wages, salaries, and benefits within your community, both in terms of their direct and indirect impact. So MHLC employs 4 primary care physicians, which comes out to a total economic impact of $5.6 million in wages, salaries, and benefits, and a total of 105 jobs within your local community. So losing 4 physicians within your community can have a really large impact on your economic base as a whole, as can adding physicians, right? So the opportunity to grow services, grow offerings, and bring more providers into your community should be viewed like an economic development tool, like you would if you were recruiting a manufacturing facility or any other job that you guys would be interested in bringing into your community. And then this is from the American Medical Association did a Wisconsin-specific study of the economic impact of physicians. So in their research, they showed that the four physicians that MHLC employs would relate to $8 million in economic output. And I really want to draw your attention here to the last bullet point. Those positions equate to almost $400,000 in local and state tax revenues, which again is really important for maintaining and growing your economic base in the county so that you can fund critical services. So as Brock mentioned earlier, you guys are a critical access hospital. So every $1 spent by a hospital in a community supports $2.30 of additional local business activity. So when your hospital is paying their employees or buying different goods and services in your community, that has a multiplier effect within the community that helps all of the businesses and all of the residents. And the average critical access hospital generates about 170 jobs and $7 million in direct salaries and wages. And I think you guys are currently at about 149 employees, is that correct? So, there's always opportunity for growth. And then some of you might be thinking, okay, that's great, but what if we could attract another type of business to Lafayette County that would have a similar economic impact? Physicians, or recruiting a physician is one of the highest economic impact activities that you can undertake. So when you look at similarly highly educated, highly paid professionals, such as a professor or a lawyer or other individuals within the healthcare field, they do not have as large of an economic impact as physicians have within their communities. And then, again, physicians are just one piece of the care puzzle. I know that MHLC employs a variety of other healthcare practitioners that are important parts of care teams, including NPs and PAs, so that's what we're looking at here. Their total labor income impact is about, or just over $3 million. So I know I just spent a long time talking about physicians, and we have to consider and remember that's only one piece of care delivery in a hospital, and there's a lot of other highly skilled, highly paid individuals working in our hospital. And then also we wanted to talk about the manor, as I believe they have a portion in the building project as well. So their economic impact is equally as important within your county. They have a total jobs impact of about 50 jobs, a total revenue impact of $4.8 million, and a total labor impact of $3.1 million. So again, really large economic drivers within your community. So the Centers for Medicaid and Medicaid Services are projecting that these expenditures in these facilities are going to increase over 65% over the next 10 years. And I think, this is probably an issue you guys have dealt with in general as we have baby boomers that are retiring and needing additional care. That's an opportunity for that facility to grow and have an even larger economic impact within your community. And then I talked a little bit about direct and indirect impact, so I wanted to illustrate that for you guys. I think sometimes that can sound like economic gibberish to people. So what does that really mean, right? So you have the revenue that's generated from your hospital, and it's spent generally in two ways. One on payroll, and two on purchased goods and services. So those purchased goods and services then support other jobs within your community, other purchases within your community, and additional payroll. So it's just more information to illustrate how, while running a hospital, I understand is a big endeavor for a county. It has outsized impacts on all industries within the county. And finally, raise your hand if any of you are local business owners. Give me a little bit idea of the audience here. Okay. Well, most business owners will tell you that one of their biggest headaches every year is rising health insurance premiums. And if any of you are self-employed, you probably have the same issue. It eats at profits. It's challenging to continue to provide good care for your employees. However, when you are spending those dollars and they're coming back into your community, it's a direct economic impact on the community. Whereas if you don't have a hospital here that can provide care for your local employees, those are your local employers sending their dollars straight out of the county, which is not what generally we want to promote. We want to promote people investing within their own communities, spending money locally, and growing their own economies. So if there's no healthcare providers within Lafayette County, that means that your employers are shipping their money straight out of the county. And then I think we're going to shift here again.
Just think of the image of a fast-moving car, a handful of cash rolling down the window and throwing it out. Because that's what that last slide reminds me of. And so we talk about economic impact and we can think dollars and cents, but so often what's missing from the conversation is the impact of things that aren't so tangible, but yet they do contribute to the vitality and the sustainability of a local healthcare organization. And so when you take a look at your own hospital, I said I've worked with so many critical access hospitals, and one of the most important components of that is to ensure that we are not an island unto ourselves. And so critical access hospitals are not meant to be all things to all people. Collaboration is key. And so when you take a look at quality being, when you talk about those vulnerability factors, quality and so forth, so what we know to be true is at Memorial Hospital of Lafayette County, they have made some significant shifts in terms of their staffing and their emergency room, and I think it's important to point out that now you have an EMS director who comes straight from the University of Wisconsin Department of Medicine in Madison. Also, your emergency room medical director and your physicians are board certified emergency room physicians coming out of acute care, and I think they're in Dubuque if I'm not mistaken. Is that no, not there. All right, so at the end of the day, you have this a really great leadership team and staff, and that builds confidence. And when people come to the emergency room, you don't want people, driving across, another county just to get emergency care. So that has an impact. Why are collaborators in care so important? Because again, MHLC does not have the kind of availability of jobs to employ, let's just say, a urologist full-time, but you might be able to share a urologist. This is a model that works in many other parts of the country where if we've got an orthopedic surgeon or even a general surgeon or an ear, nose, and throat, that type of thing, that they can share their services, and then you can cost share and still provide more than adequate service, in fact. And so they provide these essential services plus patient care plus revenue equals economic impact. And I wonder if that might be something that you haven't considered before. These are some of the other collaborators that we know. If you take a look at this list, so Medical Associates provides professional eye services, Grant Regional, 50% sharing of urologist, neurologist, you've got Madison Radiology, our WHC has therapy services they were mentioning, emergency room, lab services, imaging, you see that MRI truck, I saw it parked out there today as well, and so on and so forth. And all of these things provide revenue for the hospital, which provides economic impact and so forth. So that's why we wanted to make sure that that was part of the equation in this conversation. The other thing is affiliation. There's a lot of kind of maybe a lack of understanding. We don't know what we don't know. It's like, what's the difference between being an affiliate or if you are kind of absorbed by another organization. But one of the most promising models, in my view, around rural health is that affiliations are good for business. It's not just to be a neighborly thing to do, although it's nice to play nice in the sandbox with each other. At the end of the day, a weak hospital is not good for any region. A weak health infrastructure is not good for a particular region. And so you see here, these are actual letters that came in from Grant Regional CEO, Dave Smith, and then Lisa Schnedler from Upland Hills, and they are talking about their support for a replacement hospital facility in this community. And they sent these on because they believe that they know what it's like to not have economic viability in their communities as well. All right, so then what are some of the other benefits? Last year, or at the beginning of this year, Memorial Hospital launched an initiative called Healthier Lafayette County. And as Brock was talking about the social determinants of health, in a big part of the work that I do, we take a look at healthcare is one component. Housing, food, transportation, nutrition, parent support, early childhood development, all those things play a role in it. And so they're not trying to tackle all of that at once, but what they are saying is we want to build health infrastructure that supports a healthier county. So protecting and investing in your local healthcare facilities, plural, creating and sustaining high-paying jobs, as we were just hearing about, growing and increasing access to essential healthcare services, and of course delivering high-quality, safe care in an environment that is safe for caregivers, as well as for patients, because I think that's another issue that so many people overlook when we're talking about recruiting, and we'll talk about that in just a few moments, Healthcare environments need to be safe, not just for the patients, but also for the employees as well. Because of course, if you want to keep them and not have turnover, you have to make sure that you create a workplace environment that they feel is safe for them to practice or work in. Some other benefits that might not seem to be an economic benefit to you, but again, an engaged community is a healthy community. So you've got these, with the Walk with a Doc program, Walk with a Doc is an international program. You, Lafayette County, now are a new chapter for the Walk with a Doc program. Your providers, those who staff these, they are not being paid, so they're not being paid extra to go walk. They're doing it as a community benefit. And I guess sometimes I ask, what is the, a price tag for that? And then of course, you've seen some of the new information coming out, and it's not about advertising. One of the things that Kathy and Molly know about me is that if it's not a community benefit, we got to make sure that we are raising the bar on healthcare literacy. If we are to be a healthier community, we need to be able to have these questions asked and answered. And what a way to do it without making an appointment with your provider. You can just look into the local paper and get some answers. All right, now let's talk about some of the potential weaknesses. So we talked about strengths, and we talked about now we're going to talk about weaknesses. We know this is decisions that you all have made. We know that the weaknesses that you have is that your challenges with your facility will only grow more concerning as time goes on. These are the things that 70-plus-year-old facility, HVAC, boiler, electric systems, roof, skilled professional maintenance teams are experts, but they're not magicians, as you've heard them say before. But these are all the things that really are potential weaknesses bordering on threat at this point in time. Lafayette County was the hospital. Of course, the original section. I read all the history, and I don't know, many of you may or may not know this, but I think as the story goes, there was an ask of the county. The county committed $100,000 back in the day, and then the community decided, whoever it was, decided not to support it, took them to court, and they raised the money on their own. So this is not a new subject for you as a community, this decisive factor of whether or not we should have a new facility or a replacement facility. So there were renovations made and expansions in 83, 93, 97, 2003, 2014. And a couple of things I read today weren't exactly accurate, like I think there was a report that every room had its own private bathroom and things like that. But there's some fact checking that need to go into it. At the end of the day, you've gone through a lot of renovations, modifications, a lot of patchwork. 6 years later, in the first phase of the process, I know you also evaluated options to try and modernize the current space, leading you to the position that you are today. And this was the conclusion of this body. The board and the committee made the decision that the risk of spending millions of dollars on a hospital building that has been instrumental in your lives for 70 years is higher than investing in building a replacement facility on a green site that will serve the community for decades. So that's where you are today. Some other potential weaknesses, I'm going to go ahead and turn this back over to you because I don't like talking about the numbers.
It's very comical to me that I've somehow become a numbers person, because that was not always my strength. So I thought it might be helpful to look at some other communities that are similar to you guys. We have 43 members across the state, all in rural areas, and we have a number of them that have similar size populations to you guys. So last check, I think Darlington had 2,430 people. So I pulled communities in between 2,000 and 3,000 people. Obviously, you guys are a county-owned hospital, and you serve a larger area than just Darlington, as do all of these facilities. But it gives you an idea of what similar-sized cities have in terms of facilities. So we looked at O'Connell Falls, Hayward, Spooner, Neilsville, Cumberland, and Park Falls. So all pretty much farther north of here, but spread out across the state. And we went and looked at the age of their facility. Many of them had brand new hospitals or hospitals that were under construction, which I think speaks to the fact that rural Wisconsin communities can make viable investments into their facilities and see them pay off. Because we're seeing communities across the state that are doing that as we speak. Neilsville just finished construction. Cumberland is under construction. Hayward has a very large remodel and expansion occurring right now. So even though their original facility is from 1956, I think maybe you might have a wall left of that by the time they're done with this remodel and expansion. And then also I wanted to comment on how that correlates with economic impact. So we're seeing the economic impact of more MHLC coming in at about $19 million. And when we look comparatively, many of these hospitals have larger economic impacts. And part of that is investing within their hospital, right? They're growing their services, they're growing their facilities, they're growing what they can offer to their patients. And it's paying off not just for the hospital, but for the community as a whole, as they see larger economic impacts coming out of their hospital. And then I also wanted to talk a little bit more locally. So I don't think it's any secret to other people in this room that there are 3 hospitals that are near you guys. We have Southwest Health in Platteville, Upland Hills in Dodgeville, and then Monroe Clinic in Monroe, now owned by SSM, so I probably should update that name. And then you guys are sort of in the middle of that triangle. So when we talk about the age of the facility at these facilities, they all have seen either major construction or remodels, expansions, renovations, really within the last couple years. Southwest Health did their largest remodel in 2005, but they're currently adding a clinic addition to the facility and looking at further campus expansion, if you will, around the building. And this also shows in their economic impacts. So Monroe Clinic, Southwest Health, and Upland Hills all have larger economic impacts within their communities than MHLC. So I think if I was probably from another industry in this room telling you guys that you could grow your economic impact, you'd be interested to hear more, right? Most rural communities are interested in high-paying jobs. And that is what investing in your hospital is, and your neighbors show that. They show that when you invest in your hospital, you can grow your economic impact and the number of people that you employ that pay taxes within your community.
Get all the good news.
Scary stuff.
Yeah, threats. Okay, so some of the threats, just imagine, I mean, at the end of the day, you've got really important decisions to make. This particular facility will not live another 70 years, maybe even 5 years, it depends. So lack of support investing in local healthcare infrastructure, and then loss of control. That's another pretty significant threat. And it's a threat that's very familiar to me because I've unfortunately, maybe fortunately, have experienced this in other parts of the country. So let's just take a look, and Brock, Marie, anyone who wants to also comment on these studies. Again, Brock kind of talked about the rural hospital closure. Just touch on the numbers, if you will, please.
Yeah, absolutely. So these are 2 studies. The first one looks at rural hospitals who had or rural counties that had a hospital closure within their county, and it took economic indicators within the county, such as median income, unemployment rates, et cetera, and compared them prior to hospital closure and after hospital closure. And then the second study took counties who had hospital closures and compared them with statistically similar counties that did not, and then tracked them moving forward to see what the difference was in those 2 counties. And basically what that shows is that it doesn't just impact healthcare delivery, right? It's not like, okay, well, the hospital closes, we'll drive to the next county. You're seeing reductions in your local income for everyone countywide, not just the individuals that work at the hospital, and increase in employment rates because you're not having that hospital income supporting other businesses within your community. And you know, when income falls and unemployment goes up, that's associated with increased poverty, median rent values decreasing for any landlords in the room, we'll throw that in there. And your employment by sector is changing. So you're seeing some of those more high-paying jobs decrease within your communities, which is a challenge for your tax base. And then Lafayette County already has lower income per person and lower median household income than the state and the country as a whole. I think this data is a little dated from 2014, but it's something to think about, right? We want to set Lafayette County on the path to success, and we want to seize opportunities to grow median income and to grow employment numbers.
I'm going to hand this over to Brock. Brock, I have a question for you. We've all been involved with hospitals, with communities that lost their hospitals. How many communities that have lost their hospitals, do they get a hospital back?
The exact number I don't know, but I did see a study from the University of North Carolina that just came through this week, and we have about 32 hospitals that reopened after closure, but they did not reopen to the same level of service that they were before. They were freestanding emergency departments or some variety of a clinic, an expanded clinic operation. So it wasn't a complete return of what they had before. So It's funny, I used to be a hospital administrator in Mississippi, and we pronounce it Lafayette in Mississippi. So I'm having this block when I say Lafayette County, so sorry if I switch. So the predictors of hospital closure, again, our data partners at Chartis, Advantage Health Analytics. We took a look at what were some of the variables that when you examine hospitals that close, what were some of the reasons for their closure? So the bolded text shows those that had what we call a statistical correlation with between that variable and the closure that occurred. So the second one is average age of plant, and then some of these are more operational issues in the local facility. For example, case mix index. I won't go into what that is, but that's just a level of acuity. How sick are the patients that are being treated in that facility? Government control status was actually one of the predictors of hospital closure. Hospitals that sold to a for-profit company or sold out to a system, and then the system or the for-profit company ended up closing them, or downgrading their service significantly to where we didn't call them hospitals anymore. Capital efficiency, change in total revenue, percentage occupancy, outpatient revenue, system affiliation, and state level Medicaid expansion status. So these were some of the variables associated with hospital closure. In the same study that we looked at, we took a regression model to also correlate what some of the reductions in risk for closure would impact. What would some of those variables be? And one of them is government control status was shown to decrease the likelihood of closure by 70%. Now, why is that? Well, if you go out to western Kansas, the state that I'm from, you've got a lot of counties out there that are sustaining hospitals with populations less than yours in terms of the county size, and they're having to subsidize over $1 million, $1.5 million, $2 million a year in order to keep their hospital solvent. And so government control status, that's helping them keep them open. Now, another reason why it helps a lot is because you have access as a government entity to tax-exempt financing. And that's another tool that's very helpful in terms of controlling the cost of expansion or access to capital. Next slide. Again, the vulnerability, you heard me say earlier in the presentation that 453 hospitals are considered vulnerable. 216 of those are considered most vulnerable. And out of that 200, number of those is actually prospective payment system hospitals, or the traditional hospital that we think of. And the 76% or 165 do not have government control status. So that's kind of an interesting variable. In Wisconsin, we talked with our colleagues at Chartis. 12 hospitals in Wisconsin are considered vulnerable, and 3 of those are most vulnerable based on the data that we ran. Next slide. And I think this is coming up for my friend Michelle.
Most entertainment you've had all night. Okay, so, a lot of questions that you have about, what might be some of the other solutions. So what we're talking about is economic impact. And so what we really wanted to do was present you with some, something that we think is really important as you contemplate these important decisions. There are only a few categories of critical access hospital buyers, and my spoiler alert is they don't care about your community the same way you care about your community. So I want to just put that out there. I have never seen an instance, as Brock alluded to a little bit earlier, where someone said, I want to purchase your facility and make it something beautiful, make it a powder puff, buy a 7-year-old facility and then build a new facility for you. I've looked high and low, and a lot of state offices of rural health are tired of hearing from me, asking the question. I'm emailing people asking, and they have not found one. But I do want to talk to you about Midwest Medical Center. Are you familiar with Midwest Medical Center? All of you, I'm sure, that beautiful facility. I had the privilege of working on that project. I wasn't in charge of the financing, but I'm sharing this with you because there's a very important piece of this puzzle. And I'm using this with permission of Tracy Bauer, the CEO. She and I still talk to each other, and I worked with her and the former board chair on a presentation for the American Hospital Association College of Executives, and we really want to present this case study. So they were very similar to you. Hilburton facility, landlocked, sitting in an area where they had nowhere to grow, no room to grow, and they had a very challenging time recruiting their own physicians. They, in fact, didn't even have one employed physician at that time when they were still Galena Strauss Hospital and Care Center. And so what they did was they divested. They were actually a part of the city of Galena, and they walked away from roughly $100,000 in tax support. So it wasn't a whole lot, and they were willing to hedge their bet that when they could move to 2.3 or 2.5 miles away, that they would, if you build it, then we'll get physicians here and so forth and so on. Now the story has a really happy ending, but I will tell you one of the things that happened as a result of not having, and I'll share with you, it was a perfect storm. They had lackluster community support. That was a threat. They had a very public, vocal opposition from physicians from Dubuque who absolutely did not want them to build a hospital there. And so that was really damaging and tainted a lot of positions of the community. And of course, there was a tsunami of rumors, and it all ended up on the front pages of the papers. And it was really interesting because the editorial board of the Telegraph Herald, yes, I was trying to remember, I was trying to get rid of. Telegraph Herald, they wrote this unbelievable, scathing op-ed piece. And it talked about how the hospital wasn't necessary, so forth and so on. So we called them and said, you've never been here, you've never talked to anybody here, didn't understand anything about what the vision was, that it would be a wellness campus and whatnot. So we said, come on over, come across the bridge, and talk to the people at the hospital, and talk to the people in the community, understand. Well, that morning, a barge hit the bridge. And full confession, at the time I drove an Armada and somebody thought I had something to do with it, but I did not. And it proved the point because you know what they had to do? They had to not come over the bridge, they had to go up through your state back down again. And it perfectly demonstrated how detrimental it would be if somebody from the territory, for example, was having a heart event or a stroke or what have you. How would they get to Dubuque? So the argument of we can just go to the next hospital when seconds matter, that might not have an economic impact on you per se, but imagine what that does for your community. So I wanted to share that with you. And the reason why I'm sharing it with you is because they were financially struggling through the transitions before they had all the support. So the bondholders told them, go out and find someone to buy you. Okay? So they did that. They went out for bid. And I will tell you, the cost of putting together a package, now remind you, this is not a 70-year-old facility, it's a beautiful facility. Beautiful, with a self-playing piano and lobby, the Vista Cafe, all these beautiful things. All right, so they went out, it cost them in excess of $3 million to put together a seller's package, if you will. All sorts of song and dance, all sorts of documentation, what have you. At the end of the day, they were offered, they didn't have a line of cars waiting to provide them with bids, by the way. They were offered 50 cents on the dollar. Had to walk away. That was no deal. That was a steal, and they couldn't do it. There was just absolutely no way. So they really dug deep. If you know the CEO over there, Tracy Bauer, she took over the helm at that time. Actually, Mary Sheehan was board chair and interim CEO, and as there were no other viable offers coming in, they worked to get USDA refinancing, restructuring of their debt. And if you've gone by there today, back in the day, we said to the employees, park your cars in front so people think there's actually people here. But today, their lot is full, their cafe is a meeting place, they have meeting rooms, they're growing, they've got a new supportive living, I believe it is, on their campus, so forth and so on. And now, it's the little engine, if you will, the big little engine that could, and they are thriving, and they make a significant economic impact on their community. And, if you have friends over there, if you have board members who are friends over there, I just encourage you to talk to others. And one of the things that I talked to Molly and Kathy about is, and the folks here, they can introduce you to a lot of people who've done construction. Talk to other people so that you can understand other perspectives, because you're not on an island to yourself. Other people have been making these decisions as you're looking at now. So those are some of your threats. And now the best way to end it is to talk about opportunities. All right? So consideration of the construction impact, we'll talk about that, recruitment and retention, and then of course collaboration with regional health partners. So what you've seen, this is a very rough, this is not your facility, this is a rough draft, if you will, of just when they did the environmental study and so forth, of just a rendering of how it can be situated on the parcel of land that you've identified. So just imagine now that this is brimming with people and the parking lot is full and you've got your services. And I'm going to let Marie take over and talk about the numbers again, about what this actually means.
So, Jeremy and I's boss, who sent us here tonight, sits on the board of the Wisconsin Health and Educational Financing Authority, which is a state entity that helps nonprofits across the state finance construction, right? Because those entities are generally on a tight budget, and they need to get the best financing package available. So these are some facilities that they have financed in the state of Wisconsin in the past couple of years, and they were kind enough. 2014 is when they started collecting economic impact data, and then they decided to collect more as they went along. So there's a couple slots missing, and I apologize. But it gives you an idea of what construction might mean within this community. So, for example, Toma just built a new facility. They had their grand opening, I believe, right after COVID hit. Right before, yeah. So that was, their community was all excited. They got this beautiful new building, and then, by the way, you can't come in. But it created a payroll of $1.4 million in construction jobs in those communities. And like we talked about earlier, those are people who go to your local restaurants, they go to your local shops, and they help support your whole economic base. And it helps maintain jobs within their community, a $21 million payroll. It created construction jobs as well. And then another good one is the Spooner Health System. They were a smaller facility, a smaller economic impact, but you're still seeing $379,000 in new money coming into your community to help build the facility, and $7.7 million in maintained payroll. So these are some other rural hospitals that have undergone similar projects to sort of help you consider what economic impacts of construction might look like in Lafayette County. And then this is a study from the National Center for Rural Healthworks that talks about what impact healthcare construction has in communities. So $1 million of construction expenditure creates 9 construction employees and $322,000 in annual wages. And that's the direct impact. And then if we look at the indirect impact, 11 jobs, $403,000 in wages, salaries, and benefits, and $100,000 in taxable retail sales impact within your local community, which I think is important to point out because these things do have larger economic effects outside of just their health effects. So this is just an example. I truly have no idea what building a replacement hospital for your county would cost, but I just plugged in some numbers so you guys could sort of see it illustrated. So a $30 million hospital project is going to result in about $15 million of payroll within your community, which is significant. So.
Okay, we're rounding it out now.
We're getting close. So we'll talk about recruitment. And I am privileged to work with the National Rural Recruitment and Retention Network, and their whole focus is to help mission-minded physicians, nurses, clinicians find their first, next, or whatever their practice might be. And there's been a lot of research going into, rural health providers. It's not like, I'm going to be a doctor and then wherever the wind leads me. Because we know that rural health providers are more mission-minded, and they come to rural communities for a reason. And the goal always is that you can invite those in your community to come back to practice once they've had those opportunities. And so we know it's such a very, very important part of the puzzle because you can't just replace, as Marie was showing, you can't just replace that with another. So if you don't believe me, I think it's really important to hear from some of the providers at Memorial Hospital. So first, I would just like to invite Dr. Dan Sturma to come up and just give us a little bit of his perspective on the subjects that we're talking about here today.
Hello, I'm pleased to be able to speak to the board and also to see so many supportive members of my staff and colleagues from the hospital here. I was the first contracted specialist that joined Memorial Hospital, and I was recruited, hired, and retained. And since that time, we've had some great success with recruiting subspecialists, and we can name urology, which is my son, pain management, the mental health program that started, optometry, and then my eventual replacement here, Eamon Bernadone. The recruitment is predicated on advanced technology being available because new young doctors need that, and also a vision of a new hospital so we can have that new technology. So these people have joined and continue to join and expand our services, and that's what we need to attract these subspecialists, but also to attract and continue to attract primary care. And I think it goes hand in hand. You have specialists, you get more primary care, you have more primary care, you get more specialists. The unfortunate thing is that we've reached the limit in our current facility. We are busting at the seams. There are revenue opportunities, revenue technology necessary for improving care, and it can bring financial recompensation to our facility. We can't do it because we don't have the room. We don't have the space to do it. And these things need to be considered in the, as they were saying, the economic development of a new facility. Retrofitting is haphazard and expensive, and we just can't do it anymore. There's no space. We've seen the surrounding communities like Platteville, Galena, Dodgeville, even Lancaster build new facilities, and they not only compete for our patients that we care for, but they compete for the providers that we want to get. And imagine a provider coming and saying, yeah, I want to come to your hospital. Well, maybe I don't. You know, we make up for that with our personnel. We've done such a great job with the personnel. We wow our patients with the personnel. We can't keep doing that. We need a new facility. We need to grow and to expand and make our future bright. I think, old guys like me, I'm fading out here over the next years, and Dr. Bernadone will take over, thankfully. They need the new technology. That's the way they practice now. I can fuddle some things and get through. New young doctors can't, or they won't, or they don't. And so we need that ability. And, it was good enough for me, that attitude, and I've heard that expressed, good enough for me, it should be good enough for the future. It's not going to be good enough for our community, and it's not going to be good enough for the young people that we want to recruit as physicians and providers. So I guess what I'd summarize in my little presentation here is that I believe Memorial Hospital and in particular Lafayette County should move forward with a new facility to recruit and retain specialists, a new facility to support our strong primary care department, a new facility for new technology and new revenue-producing procedures and services, and a new facility for the health of our community. It might be a field of dreams, but we have the providers, we have the patients, we just need the facility. So with that being said, I'd like to introduce Amy Tibbetts.
Thanks, Dan. Appreciate your input there. Dan's been a fantastic asset to our community. As everybody knows, he's a fantastic orthopedic surgeon. I'm Amy Tibbetts. I'm one of the physician assistants at Memorial Hospital, Lafayette County. The rural healthcare really is what attracted me to Lafayette County. I grew up, it was funny that she mentioned O'Connell Falls Hospital. That is 10 minutes from where I grew up, and actually where my mom sought services when she had a stroke when I was young, and what drove me into coming to Lafayette County is the rural health. And so what I love about Lafayette County is being a part of the community. So I live in Mineral Point. It's technically Iowa County where I live, but Lafayette County is so close. All of the people that I work with at the hospital are vested in the hospital. We all live in the hospital. It's so great to work at Lafayette County here because I feel like I'm helping improve the community. I've worked at multiple other facilities. I've practiced for 15 years. And the benefit of being here is the fact that we get longer appointment times. So as the rural health guy here talked to us, the lower volume. So I feel when I've practiced other places, I've just had to speed through things. And I can't really make you healthier by just refilling your meds and talking to you for 2 minutes and not knowing what's going on. So when I'm practicing here, I actually have the time and the resources in order to make better decisions and to make Lafayette a healthier community. And so I just really feel that you guys as the county board need to know how much the CEO and COO, Molly and Kathy, have done for the community and are continuing to do, and how important that this new facility is to keep people healthy in Lafayette County in order to support our further vision. So with that, I am going to introduce Lisa Borgman. She's one of the nurse practitioners that I get the privilege of working with, and she's here to talk next.
Thanks, Amy. My name is Lisa Borgman. I am a nurse practitioner. Just a little information about myself. I have been a nurse for over 20 years now, 21 years. It's kind of scary for me to say that. I have worked in, like Amy, a multitude of facilities. I worked in inpatient hospital care my entire career until I became a nurse practitioner. I worked in teaching hospitals, I worked in mid-level hospitals, and what I see in our facility is the ability to care for our family. We are taking care not of just our community, but we are investing in our families. And so when we look at our current structure, we look at the way the clinic is set up, we look at how we bring patients into the clinic, how we care for patients in our hospital, what we see is this need to better care for our families. So one of the things I think when we look at our goal for this replacement facility is how we want to invest in our family and their safety. When I compare where I work now in the clinic to some of the larger teaching hospitals that I have been to, I can tell you that space is a big thing. Space is a big deal. If you haven't been in our clinic lately, you'll notice that the long hallways make it very difficult for patients who have ambulation trouble to make it all the way down without being short of breath. They struggle with the small doorways, getting wheelchairs in and out of the clinic. So those things might seem, things that we can work around, but I can tell you that when you take the time to invest in the safety and the care of your patients and you bring them that knowledge that you're invested in them, we're investing in our family. And it comes through when we take care of them. They talk about how much they love being able to see their doctor every day. They love being able to see the people who are taking care of them every day. And as a provider, I think it's really important to bring that forward, to show them that I'm invested in them and I'm invested in their safety. So that's kind of, my idea on how we, this replacement facility could be really helpful. It's going to benefit our families. I'm going to introduce Marty Cleary next, but I want to tell you a really funny story. I was recruited by Dr. Cleary, and he recruited me at the end of my driveway, standing underneath a tree as his son unloaded cows into my pasture. And he talked about the excellence in care that he got to give here. And if you haven't had a chance to really be a part of that family, being pulled in by someone who is so committed to their facility and so committed to taking care of their patients that they're willing to stand at the end of my driveway as the cows are mooing in the back and say, you really need to take a look at this. You really need to come and see how, what we're all about. And that's really a big reason, that commitment to patient care that I chose to came here. Okay, so I'll turn it over to Dr. Cleary.
I'm Marty Clary. A lot of you know me and have been in the office with me before as patients, a number of the county board members. A brief history on myself, I practiced in Warren, Illinois, which you all know where that is, just across the border, from 1985 until 2015, 30 years. Left there and was pretty much going to quit practicing, and then I kept getting pestering phone calls from Matt Silverson and Kathy Coopers and Julie, and the calls were almost on a daily basis. Finally, it broke down.
That's annoying.
I couldn't ignore them anymore. Yeah, it does. So finally, I came up and talked to the three of them, and ultimately, Matt hired me for the practice before it was purchased by the hospital, and that was in 2015. It's hard to believe it's been 6 years already, but I have to say, after practicing for 35 years, like Dan said, it's been a fantastic place to practice. As Lisa said.
We've talked too much, you're doing it right now.
Well, as Lisa said, the way the system works, for primary care at least, is that we do have time to take care of our patients. And anyone that's been in the office with me knows that when Kathy told me I had 1 to 2 minutes to talk, that probably wasn't going to happen. But in any case, so started here in 2015. I had a huge practice in Warren, Illinois. I didn't know if any of them were going to follow me here. As you heard, the facility doesn't look the greatest from the outside. On the inside, it's even worse. But over the last 4 years, I would say that probably 50 to 60% of the patients that I see are patients of mine from Illinois. Easily 50%. 2/3 of the patients I see every day are from Warren, Apple River, Stockton, Elizabeth, Lena, Freeport. And once you get them up here and they meet the staff, whether it's at the hospital, the nurses at the hospital, the nurses at the clinic, the specialists that we have now, I have no trouble getting them to come back. And we even at this point have convinced the Stockton Ambulance Service that they're willing to take patients here instead of Freeport or Monroe for their emergency care. And if a person's having a heart attack, they won't take them to Freeport, they'll take them to Midwest Medical Center because it's the closest. But the only thing that's lacking right now to keep those people coming is, because like Dan, I'm not going to work forever, is a facility that meets their vision of what a healthcare facility should look like. The staff is fantastic. They're nice to patients. Patients like that. Patients from Illinois like to drive to Darlington. They come and stop at Piggly Wiggly. They go to Annie's. They go to Lenny's. A bunch of my patients make their appointments on Friday afternoons so they can go to the stock car races. In fact, on Sunday I was at Stockton getting some plants for my garden, and I was talking to a guy from south of, because I'll talk to anybody, he's from south of Freeport. I said, I'm from southwest Wisconsin. He said, well, yeah, there's a real nice town up there. It begins with a D. I said, a D? Yes. I said, Darlington? He said, yeah, that's a great place. We go up there a couple times a year just to take the drive and have lunch. So in any case, I think when I'm not in, my patients come to see the other providers in the clinic. They all come back. So, it's not just me, it's the other staff, the PAs, Matt Silverson, Don Hay, Nick. I think we provide really, really good primary care. And our specialists that we have now are as good as anyone anywhere. There's a lot of competition for urology and orthopedics. Those guys are busy. They need a bigger facility to do that. Now, Kathy wanted me to also mention that I live just south of Lee Gill, just off of W. I go to Monticello Township. I own farmland in Wisconsin, and a house, and so I pay plenty of property taxes to Lafayette County. They're cheaper than Joe Davies, and hopefully they stay that way. But so anything that's done financially with a new hospital will impact me also. But I really think that given the fact that if we do have a new hospital and more providers, the service area of this hospital would stretch down into the middle of Joe Davies County, probably not over to Galena, but certainly into the middle of Joe Davies County and the eastern half of Stevenson County. For those areas, it's not much more of a drive to here than it would be to Monroe or to Dubuque or to Galena. So I think it's a big opportunity for the county in terms of its economic development. And speaking firsthand, the patients that come up here, I don't have any trouble having them come back. Whether it's the emergency room with our new providers, which are fantastic, or seeing Dan or Ian, to me it seems like a no-brainer. So I'll be around if anyone has any questions afterwards. Thanks for your time.
Great, thank you very much. Very interesting to hear that your patients followed you here, and it could very easily be reversed. And that's a concern that so many of our rural hospitals have, is people say, well, just make a day of it somewhere else, and they're taking their dollars elsewhere. They're making a day out of going to their provider. So quick recap, and then we're going to have questions. And I'm sure everyone's going to pop up because you have questions. We presented you with a lot. Engaged providers, you heard it here yourself, and staff a plan for the future. And right now, you have local control. And one of the things that we talk about is, what if someone came in here and they said, well, we'll make you an offer you can't refuse, and we promise you that you'll be able to keep all your staff and your providers and so forth. And I asked Brock about that, and I think your answer was something to the effect of, what do you want, or something like that. Because it normally, you said something about it depends on how much money you're willing to spend on lawyers.
Yeah, if you want to unwind something.
Unwind something after it's done, because you no longer have any control. So right now you have local control. Your weaknesses, your physical plant, there's no going around it. 70 plus years old, landlocked, regional competitor practices. They'd be more than happy to take your lion's share of patients and the realities of mergers and acquisitions. We just gave you a little bit of snapshot. There's a lot of data out there if you're interested in more. Your threats, lack of county and community support. That's a potential threat. Time is of the essence. Risk of closure, loss of control, stripping the hospital of profitable services, and of course that has a major threat for the county in itself. And then finally, we ended on the good note, which are the opportunities, retention of good-paying, high-paying jobs, and talent, construction jobs, new revenue, recruitment and retention, new services, and at the end of the day, healthier Lafayette County. So you can't, there's some things that you can't just put a price tag on, and that would be one of them. So with that, I would just like to invite you to have a question. If you just want to come up to the podium and ask your question, and any one of us will be able to answer. And again, we're here to answer questions about the economic impact and what we presented, not about any specifics about your numbers or anything, because we don't have that information. So if you ask, I'll make up something. So, and we're being recorded, and I don't want that to come back. Any questions? Somebody's got to break the ice.
I forgot my eggs and tomatoes.
Okay, my question is about acquisitions. There is a hospital in Wisconsin that was acquired by a conglomerate, and it's of interest to me. And what I've been hearing so far is that there was a part of the agreement that they never contemplated what the physicians would do from the conglomerate, telling their patients, no, we're going to do the surgery back at the home hospital. We're not going to go out there. And what it really comes down to, in the opinion of some, is that the physicians just don't want to make the travel. They don't want to do the drive out to that rural location to do that surgery, that procedure. Does that sound familiar?
You do, I mean, that's some of the insurance practice that we're seeing, what you call as sort of a steerage, that they might steer back to sometimes their home facility as opposed to have specialists or others see at that facility. But I mean, I guess what I heard tonight is that you have physicians in the community that are willing to see, and so that lack of, it is something that happens more often with a system-owned or affiliated hospital. And of those 43 hospitals that we have at the co-op, roughly half our system and half our what we can call freestanding or
Can
independent.
I make a comment about that? Good question. The way our system, it's a system, MHLC is a healthcare system operates. Since we are independent, patients that see me can go wherever they want. And if they need heart surgery or knee surgery and for some reason don't like Dan or want to see a specialist, we send them wherever they want to go. So if they want to go to UW, that's fine. If they want to go to Mayo Clinic, that's fine. It doesn't affect us. So really, one of the more common questions I get when people come into me is, well, if you needed this done, where would you go to have it done? And I'll be honest with them. I mean, my wife has had surgery at our hospital. All of my children have been treated there. What we do well. But what we don't do, or if the patient's afraid to come here, we are more than willing to send patients to UW, to Dubuque, to Iowa. We have no legal or systematic plan that makes us direct patients in a certain place. So that's very important for a community. So that's one positive, one of the many positives of keeping the healthcare local and controlled by people in the community rather in Madison or Chicago or Milwaukee or someplace like that, where they want your profitable business. They don't care about the non-profitable stuff.
Yeah, in addition to the insurance steerage that Jeremy mentioned, there is a tendency around the country, and I've seen it happen a number of times, where a system hospital, whether it's for-profit or not-for-profit, it doesn't matter, they will often make decisions about what's offered in the local rural hospital and bring those services to the larger hospital in order to economize. And so what happens is you take a lot of the more profitable rural services out of the community and bring them back to the system facility. It can tend to do what we call hollow out the core services that the hospital offers in the local community. And that then creates this spiral where then magically several years later, that local rural hospital is not generating a return for the system any longer, and then that's when they start making those decisions to close the facility or to downgrade it to another level of service.
And if you don't have those specialists employed in your community, their economic impact vanishes, right? So they no longer have a nurse, they no longer have a medical assistant, they no longer have administrative staff supporting them. They're not paying taxes that support your school district or your county services, so.
So I'll just say, an example as a health system in Idaho that I worked with. A health system purchased for critical, they don't like to use the word purchase, they call it acquired. I'm not exactly sure what the difference is, but they acquired 4 critical access hospitals. And they assured, and I was there, I went to every single one of them. I sat in a room with a lot of people and a lot of tears and distress, because all of a sudden, then the CEOs were now called something else, site administrators. And so the maintenance guy who'd worked there his entire adult life is now reporting, he has a dotted line to the person there, but a direct line he's reporting to the system. And exactly as what Brock said, they started saying, we're removing this service, we're removing this service, we're removing this service, and then all the profitable surgeries would go to what we refer to as the mothership. You might know that term. And then they were stripped down to nothing. And so there's a lot to be said about not just the economic impact, but the emotional toll that it takes. So that's another factor.
It's like I have someone come in, but the other thing I'd also say is sometimes you get your back office support. So your finance or your patient business office, I mean, they will economize those back again to sometimes the larger system.
So I just want to make a comment on something that Dr. Zermatt touched on earlier, and that's technology and new physicians. And when we look at our current facility and the idea of us, patients turfing out or steering out patients for different surgeries, when it comes to new technology, the capabilities that the physicians have nowadays with electronic ICUs or remote ICUs remote critical care access. When we talk about building a replacement facility, having the option to integrate into that future care is really important. Lots of current facilities, including FHM, have EICUs that are collaborated with university hospitals. It allows us to keep our patients here longer to provide a better, a higher level of care. Now, as a provider here, I know that we have the skill and technology to do it. We just don't have the facility. As a nurse who's worked with an EICU, being able to collaborate with university physicians as we did up with UW, those patients are cared for in collaboration with those providers, which means they stay home. And I can't tell you the number of times that patients have said to me, I want to stay here. I don't want to go to Madison. Why can't we keep it here? Building a replacement facility allows us to expand on that technology, allows us to grow in that way so that we can provide care to these patients and keep them home longer.
I'm Tim McGettigan. It's nice to be here tonight and see such a great crowd. You know I talk loud, I don't need a mic. Don't give the mic to Tim, he talks too much. Couple questions and then a comment. Are all of the, did I hear correctly, all of the hospitals around us are critical care institutions?
Monroe is a PPS.
Okay.
So critical access.
And we're classified now as what, a county-owned institution?
But you're still critical access.
Still
It's
critical
just a
access.
different reimbursement model.
Yeah, it's a designation by CMS, critical access, and they are known also as necessary providers, is another term for it.
Thank you. The revenue that we've been generating in the past from our hospital being well run, of course this past year has been a non-typical example, I'm sure. Where has that been going? Has it been building in a capital position? I'm sure some of it's gone into expansion and improvements. But are we building our capital position in our hospital on our balance sheet?
Unfortunately, Tim, not really. I've been around here a long time. I've seen years when the hospital made quite a bit of money, when we took as much as $250,000 to either fund different departments that lost money or used it to put against the county levy to lower it. So we had wiggle room to continue services. I've seen that dwindle. I've seen years that it's, we didn't take anything. I've seen years lately where I swore I wouldn't ask, and I've asked for $50,000 a couple of last years. There was a point in time when it was $250,000, as I said. We lowered it after that and didn't ask for that many dollars because we knew that a lot of things needed to be put back into equipment and things like that at the existing hospital. So unfortunately, the county has not, had a set-aside fund for a new building all these years. We've used it pretty much for tax relief. And I think there's a myth out there amongst a lot of the taxpayers that this hospital is costing me money on my taxes. No, you're getting money off your taxes because of this hospital.
I appreciate that response, Jack, because as you say, I think there's a lot of misunderstanding out there about that. I won't ask the follow-up question about what we're going to do in the future. But that's probably at further meetings down the road when we can look at operating statements and balance sheets. The last comment I want to make that has been repeated many times tonight, if you want to talk to someone that worked in a successful institution that had 37 employees, had $100 million in assets, and I thought we served the community well, and I had way over $1 million payroll with fabulous benefits for my employees. And somebody came along and offered the stockholders a golden apple, and it was acted on by my directors. Now, look at the institution that I used to head up.
An empty building.
Sits down across from Piggly Wiggly, vacant. So all of the pluses and minuses, I can give you a real good reaction to what I experienced. So I think a lot of the points that were made tonight are very, very, very important for us to consider. Thank you.
I want to thank you for your comments, Tim, and that's a very good point. The Citizens Bank that you referred to was a very good community player, a very important part of a lot of people's lives here with checking accounts, savings accounts, loans. Did well by the farmers around here, and when it got sold off, it got sold off then again and again, and I lost how many tracks again, but a beautiful building down there. No employees, no benefits, no nothing for Lafayette County. That's a good analogy right there.
Any questions about the economic impact of rural health infrastructure and investments and whatnot? I know that there's another meeting coming up in June, probably another one in July. You meet here routinely. But I also know that this presentation will be available on the website tomorrow. Molly will be able to put that up there. And again, if you have any questions of any of us, we're here tonight to answer. You won't have brain power like this in the same room, like every month, so I would take advantage of it. Kathy?
Would you ask the employees of Memorial Hospital?
Yeah, I should. So for those of you, you call them employees, I call them caregivers. So with all the caregivers of Memorial
We call them
Hospital.
heroes.
Yeah, heroes. Just make yourself known, just stand up if you wouldn't mind. I know you're here. You've got your shirts on, so you can't. So there's nothing further of us. Brock, anyone have anything else to add?
Thank you guys for listening. I know we talked for a long time, and I'm sure, some of you could go for a cheeseburger. So.
Are you buying?
Thank you.
Because you are the numbers lady. Thank you.
Thank you very much to Michelle, Brock, Marie, and Jeremy for that presentation. I'd also like to thank the providers for coming up and speaking tonight. That was very well done also. Very good presentation. Sometimes I think I know too much or I know it all, and I learned a lot of things here tonight too. I looked at a different aspect of this, the economic side of it, that I've thought we should look at for a long time. So